afternoon, everybody. At the very outset, let me thank the organizers for giving me this wonderful opportunity to participate in this exciting conference and to talk to you about the pre-surgical evaluation of the diabetic patients. Patients with diabetes, we all understand, have a very high incidence of morbidity and mortality, and poor perioperative glycemic control increases the risk of the adverse outcomes. Treatment of postoperative hyperglycemia definitely reduces the risk of the adverse outcomes. A lot of changes occur in diabetic patients because of the metabolic stress. First of all, there is a metabolic effects of the starvation. The patient is starving pre-surgery, during surgery and post-surgery, which is a catabolic state, and it stimulates the counter-regulatory hormones. Though they can be attenuated in patients with diabetes by giving infusion of insulin and glucose, the metabolic effects of major surgery are the neuroendocrine stress response with release of counter-regulatory hormones, which are the epinephrine, glucagon, cortisol and growth hormone, and the inflammatory cytokines IL-6 and tumor necrosis factor alpha. The catecholamines, norepinephrine is augmented during surgery and epinephrine is augmented postoperatively, and both of them stimulate gluconeogenesis, glycogenolysis and cause inhibition of the glucose utilization by the peripheral tissues and also inhibit the insulin secretion. And the anabolic role of the insulin is reversed or attenuated because of the stress of the surgery. The counter-regulatory hormones, the hormones epinephrine, glucagon, cortisol, growth hormone, they have the opposite effect to the insulin, and this is achieved by stimulation of gluconeogenesis. The complications which are incurred by the diabetic patients is the impaired wound healing by the hindering collagen production. Increase in infection is because whenever the blood sugar levels are more than 250 milligrams per deciliter, it impairs the leukocyte chemotaxis and phagocytosis, and abnormal coagulation due to increase in plasminogen activator factor inhibitors and abnormal platelet function. A thorough perioperative evaluation needs to be done. Determine the type of diabetes. Ensure that the patient is very well controlled blood sugars before subjecting him to the surgery. Review all his medications. Consider the presence of complications of the diabetes and identify high-risk patients which you would require to shift them into critical care after the surgery. The preoperative evaluation needs to be done very thoroughly in assess the patient's blood sugar control by doing his sugars fasting, postprandial and HbA1c. Have a look at the nephropathy by doing urine routine, albumin and renal functions. Check on the cardiac status by the ECG, X-ray, echo, TMT, and the peripheral vascular disease by the history of intermittent claudication and non-healing ulcers. Retinopathy needs to be assessed by the fundus examination and autonomic nervous system by the postural change in blood pressure, HR variability with exercise, tachycardia and response to atropine. Have a look at the electrolytes and the ABG on the urine ketones and serum electrolytes. Airway needs to be thoroughly assessed before. Because of the scleroderma of the diabetes, look at the stiff joint syndrome with the prayer sign and the palm print test. Have a look at the X-ray cervical spine if the patient has a short neck or not, because all these things are going to be very, very important during the surgery. And in general, these principles need to be followed, that patient should be very well controlled prior to elective surgery. Avoid insulin deficiency and anticipate increased insulin requirements. The patient's care provider should be involved in the management of the patient right from perioperative to operative and subsequently to postoperative care. Patients must be given very clear instructions, and preferably they should be taken in the morning list, but we can always Tailor-made the dosages also and take the patient in the afternoon list also. And very important is the patient should be well hydrated before the procedure. Diabetologists, always the major concern is about the hyperglycemia, while the surgeons, nurses and anesthetists are always worried more about the irrational fear of the hypoglycemia. Looking at the metabolic responses to surgery, the surgery causes stress because of the hemorrhage, the trauma and the wound infection. And this stress produces increase in the counter-regulatory hormones producing catecholamines and cortisol, which reduces the insulin sensitivity, and also the increased sympathetic activity inhibits the insulin secretion, and both of them together cause increase in glycogenolysis, proteolysis, lipolysis, ketogenesis and gluconeogenesis, and hence producing hyperglycemia, loss of proteins, ketones, and perioperative starvation contributes to the ketosis. The complications, the dehydration from the perioperative hyperglycemia, this may result in MI or CVA, and in the patients already those who have peripheral arterial obstruction. So hence the hydration is of the extreme importance. Similarly, in patients having complications with the nephropathy, the radiological procedures involving IV administration of radiograph contrast material can precipitate acute renal failure, and hence also these patients should also be hydrated with IV fluids, and they should be observed for any declining urinary output. For patients with minor surgery who are going to miss only the morning meal, who are going to miss only for the minor surgery and they already have a good glycemic control, the sulfonylureas, the longer acting one, can be replaced with the shorter acting sulfonylureas. They can be operated in the morning. Omit the morning OHA when you omit the morning breakfast, and when the patient is ready to take food, the OHA can be taken with the next meal. Patients who are for major elective surgeries which are not treated on insulin, but they have a poor glycemic control, they should be admitted before, stabilized, and they should be operated in the morning, and during surgery the IV insulin and glucose infusion should be started and blood glucose to be monitored very closely, and subsequently post-operatively to be shifted to the subcutaneous insulin. Patients who are for the elective surgery who have a good or a very poor control, they should also be stabilized before the surgery, preferably operated in the morning, and omit the morning insulin dose, monitor them very closely, and restart subcutaneous insulin as soon as the patient is ready to take a post-operative meal, but discontinue IV insulin 30 to 60 minutes later after giving the subcutaneous injection of insulin. Patients who are on only diet control, they are well maintained, nothing needs to be changed for them. The blood glucose levels, they should be maintained around 180, and if the perioperative period is long, IG infusions, the glucose and the insulin infusions can be given. If the patient does not become hyperglycemic following the surgery, the blood glucose levels can be monitored every 4 to 6 hours. The perioperative adjustment of the OHA, if the patient is for only a one-day surgery, which surgery may be even laparoscopic cholecystectomy, hysterectomy, where the patient is going to miss only one meal, there is no need to change the OHA one day prior to the admission, but prior in the morning when the patient is NPO, the acarbose, voglibose can be omitted. They should be omitted, but if the patient is posted for afternoon surgery, patient can have them in the morning. Metformin can be given if it is a minor surgery, but if it is a major surgery, metformin should be omitted. Sulfonylureas, the glipizide, gliclazide, during the day of the surgery, omit the morning dose. If they are on twice daily, again omit the morning dose, but patient can take the evening dose. For the afternoon surgery, both the dosages need to be omitted. Pioglitazone, no change is required. DPP-4 inhibitor, they should be omitted on the day of the surgery. Patients who are on OHA but they are without the insulin, the only thing is the OHA, the long-acting sulfonylureas can be changed to the shorter-acting, and the morning dose have to be missed. And during surgery, if it is a long surgery, the patient should be on the glucose insulin infusion and subsequently requires insulin post-operatively. Metformin, for the minor surgeries, metformin need not be stopped, but if the patient needs an IV radio contrast, if the creatinine is more than 1.8, withdraw metformin at least 48 hours before. The controversies in the diabetes regarding the blood glucose target, that if the patient is undergoing all these associations, the American Association, the Critical Care Association, the American Heart Association, agree on to this, that patients on medical or surgical patients, the blood glucose target fasting 90 to 126, random less than 120. For the cardiac surgery, a very tight control of less than 150 needs to be maintained. For a critically ill, again a tight control of less than 150. And for acute neurological disorder, 80 to 150 milligrams, such a tight control needs to be maintained. The tighter control, the risk is that of a hypoglycemia. Hence, the hypoglycemia, the adverse outcome is associated, as the NICE guidelines had shown. Hence, it is recommended to keep the blood glucose levels between the range of 6 to 10, but also 4 to 12 millimoles per liter is acceptable. Fluid management is foremost important, as the National Patient Safety Agency recommends that hypotonic fluids, that is 5% dextrose alone, they should not be used. Half saline with dextrose with potassium, though isotonic in vitro, it is the hypotonic in relation to plasma. This is the ideal fluid, but it may cause hyponatremia. But replacing with normal saline 0.9%, it may cause sodium and chloride overload. Hence, the recommendation is of the 0.45 saline and dextrose along with potassium. And for patients not requiring variable rate intermittent insulin infusion, ringer lactate Hartmann solution can be used. A normal saline in excess will cause hypercholoremic acidosis. The perioperative adjustments of the insulin dose needs to be done. If the patient is going to miss one meal and the patient is on Lantus, there is no need to change the dosages one day prior, but during the day of the surgery, check the blood sugar. It can be given as such, and for the afternoon surgery also check blood sugars. But if the patient is on 30/70 or on Humalog 25/50, during the day of the surgery, half the usual morning dose, check blood sugars on admission, and leave the evening meal dose unchanged or change it if the patient is taking little meal only. But for the afternoon surgery, half the usual morning dose, check blood sugars and leave the evening meal dose unchanged, or if the patient is not eating, drop the amount of the insulin. If the patient is on 2 daily separate injections of shorter acting Novorapid and intermediate acting insulinotide, calculate the total dose of both morning insulins and give half as intermediate acting only in the morning, and pre-mixed morning insulins half the morning dose and omit the lunchtime dose. And of course, we have to check the blood sugars on admissions. The insulin regimens during surgery, the variable rate intravenous infusions, this is how we maintaining the IV line along with the soluble insulin in 50 ml of saline, but going ultimately through the same port. 50 ml of saline with 50 units of soluble insulin, and the substrate solution to be used alongside is the half saline with 5% glucose and potassium, and the rate of the fluid replacement must be set to deliver the hourly requirement. This is the GIK infusion where everything is together. If the patient is having diabetic ketoacidosis, we manage the standard care of the diabetic ketoacidosis management. Similarly, if the patient is having HONC, similarly we need to correct the fluid replacements as we normally do in HONC patients. And a tight control regime, that is 80 to 110, is required in surgeries of cardiopulmonary bypass surgeries or neurosurgeries. And fluids needs to be monitored very closely. Insulin infusion rates needs to be adjusted, but the risk of hypoglycemia needs to be avoided. If there is hypoglycemia, this needs to be treated this way only. During emergency surgeries, when there is little time to stabilize the patient, but if 2 to 3 hours are available, it's important to correct the fluid and electrolytes. Correct hyperglycemia by IG infusions if sugar is more than 180, and promptly treat acidosis but avoid hypoglycemia. Surgery should never be delayed in an attempt to eliminate ketoacidosis completely if the underlying condition will lead to further metabolic deterioration. But if enough time is not available, correction of hydration status, electrolytes, acidosis, blood sugars should be started and should achieve at least an improving metabolic trend before starting anesthesia. Likelihood of intraoperative hypotension and arrhythmia is more particularly if the patient has preoperative acidosis or hypokalemia. Intraoperative sugar to be monitored more frequently, at least hourly and half-hourly. And when the patient needs to be transferred from variable rate insulin infusions to subcutaneous, the OHAs can be given with the first meal, and subsequently subcutaneous insulin also can be started when the patient starts taking orally and he doesn't have nausea and vomiting. But important is that the variable rate insulin is to be maintained for 30 to 60 minutes after the subcutaneous insulin injection is given. Hence, summarizing, we have to ensure a good glycemic control, a very proper pre-op assessment, and hourly blood sugar monitoring, target the blood sugar between 90 to 180, and substrate fluid to be used as half saline, dextrose, potassium, or even needed as normal saline, avoid prolonged fasting, start intravenous glucose infusions, and with variable rate insulin infusions which are more flexible. Thank you very much.